What's going on? Dr. Thomas Helfst at the resident professor on Instagram. Excellent. Hey, I gotta give you an intro, right? You deserve it.
Sounds good.
How's it going?
It's going well. How about you? How's residency going for you?
It's going. It's going in one direction or another.
So where are you now? You're in third year?
I am, yes, second half of third year.
Okay.
Just going forward, moving forward. So you had a little change of places recently, huh?
I did. When I got out of my program, I was at Lincoln Hospital. So you guys are familiar with us, I'm sure, with trauma like you guys. Went into private practice, 1999, was an associate for a couple years up in Scranton, PA. Things didn't work out contract-wise, so I decided to open my own practice. It was a little scary at first. So I opened up in Stroudsburg in the Poconos, and I worked from 2021 when I closed my practice. Reason for closing, COVID hit. I had a relatively small office staff, but very successful office pretty quickly. We had 2 front office people, 2 back people, very efficient office. COVID hit. People kind of wanted to bail out, if you will, collect unemployment. So I called around. I was going to join a bigger group practice in the Poconos, St. Luke's. And so the owner of that practice did his residency at Montefiore. So I knew the director at Montefiore because he was my director at Lincoln for my first 2 years. Dr. Hydrotimer. And then after the 2 years at Lincoln, he went off to Montefiore after that. So I called him up and I said, hey, what do you think of the owner of St. Luke's? Is he a good guy? You know, I'm thinking of joining their bigger group practice. He said, Tom, he's a straight shooter. I trained him at Monte, good guy, but we're expanding our clinic. So why don't you come visit us because we need an attendant? And so I went to visit him and they kept me and I was there for 3 years. This job opportunity up in Rochester came up recently and I recently became their program director on February 5th of this year.
Congratulations, February 5th.
Yeah.
That's March 4th, less than a month ago.
Yeah. And we were not on pass for a while. I got that started because no one could really find us, if you will. We're interim accredited by CODA, but no one was able to apply to our program. So we got on pass mid-November and we ended up interviewing, we had 44 applicants over 2 weeks. We interviewed about 33 and I ranked 17 and I got my first and third pick. Excellent. For 2 slots. Yeah.
That is huge. Yeah. Oh, and I also just really quickly, I meant to thank you too for taking the time tonight. We had some scheduling issues last week, this week. So I wanted to thank you for that. But wow, so this is excellent. Yeah. You got to be on pass. I mean, we all know that now. That's the standard of applications to all programs and all specialties, even for the most part. I mean, endo is its own thing, of course, right? You have pass 1 and then the second pass in oral surgeries and the main application cycle, whereas like ortho's a little bit earlier or whatnot.
Right.
But wow, so this has been moving pretty fast for you. You were only at Monte for 3-4 years?
3 years, yeah. I started back in 2020 in October, and then I finished up this past February.
Right. Yeah, really. So it was October of 2020. I could have sworn that I met you in one of the clinics when I externed there. That was end of July 20. That was I could have sworn that we met. I thought we were in op together.
Maybe.
Yeah.
It would have been fun having you in our program, Brendan.
It would have been great. In hindsight, well, for another,
it's a good program. It's level 1. I'm a big fan of level 1 trauma training because that's where I came from. So
true.
I think that gives you your best training trauma, to tell you honest.
That's for certain. There's definitely a lot of trauma that comes through here. How about Rochester? What level are you guys over there?
We're probably level 2. We're similar to Monte. The good news with us, we control the call schedule. So we take about 80+% of facial trauma call. And we only share it with ENT. Plastics does not get involved.
Really?
Yep. Unlike Monte, believe it or not, Monte is 50-50. It shares its trauma with plastic service. It doesn't share with ENT, but it does share with plastics opposite days. So one day's OMFS, the next day's plastics, and vice versa.
That's right. As I remember plastic surgery at Monte, and so you're with ENT, but you're taking 80%. So 4 out of 5 days you're taking.
Yeah, and the good news is we control the call schedule, so we actually put ENT on the schedule. So we're making up the schedule. So I wanted to keep that when I went up there. I'm an additional attending up there, so that's good news for the guys who are already there, but they were taking a fair share of trauma call, and they kind of wanted ENT to help them. And I think they were giving maybe a little bit of it away, but now since I'm there, we're gonna keep our 80%, maybe more. We'll see what happens.
That's excellent. Yeah.
Yeah.
Yeah, maybe a little more. Squeeze some more in there.
Sure.
Great. So 20 years of private practice. What do you see the difference? Do you like it? Because it's 20 years under your belt there, more, but 20 years in your private practice, right? A couple of years at Monte. Now you're starting up with Rochester. How do you like the academic setting compared to all those years, in your own neck of the woods, if you will?
Miss private practice. You get to do a lot more surgery. You're your own boss, so that's always exciting. As far as teaching goes, I love it. Anytime I can describe the procedure and walk the resident through just in speaking terms, because at Monte and similar at Rochester, we let the residents kind of run the show. They're doing the surgery. So for the most part, we're holding hooks and we're teaching them. So anytime I can, describe the procedure and have the resident perform it, it's such a elated feeling that they accomplished. So that's my favorite part about teaching.
I love that. And so for people listening to this episode later on, what holding hooks or holding sticks means is who's doing the retracting on the procedure. In some cases, right? The cutting is what we're referring to here at Montefiore, and now that you're at Rochester, you can see that you're doing it there. My program here, we do it there, but as we all know, out in oral surgery, not all programs allow the residents to do the majority of the cases. And yes, that does affect training, right? Watching is one thing. You can watch someone do push-ups all day long, but until you're doing push-ups yourself, you're not building real muscle, right? You're learning about it. So I think that's so crucial. And so for people listening to this that are interested in oral surgery, you gotta look at programs out there. You gotta extern. That's how I think we met. We actually met years ago. And that was something I was very impressed about Monte. So it's pretty exciting to see that you're taking that to Rochester and doing it up there. What about locations? It's a big difference from the Bronx.
It's a pretty area. It's wine country. Finger Lakes is close by. So from that standpoint, it's nice. There's less traffic. There's less hustle and bustle. So it's kind of taking me back to my roots where I kind of grew up on Long Island in South Shore of Long Island, West Islip, and the Poconos were similar. So I kind of like that atmosphere, to tell you honestly. I didn't mind the Bronx, to tell you honestly. I think that's, if it's a busy area, it's going to give you good training. But, traveling through New York, traveling through Manhattan, busy traffic. So it tends to raise your level of stress, I would say, besides residency.
100%.
So to have a nice atmosphere surrounding you, it kind of takes that stress level down, and maybe you can enjoy your work a little bit more from that.
Absolutely. I didn't know you were West Islip guy.
Yeah.
I didn't know that. I'm Smithtown.
Oh, there you go.
So you were there. So you born and raised there, or did you move around at all?
Born and raised in West Islip. Did my undergrad at Helfst in Hempstead. Did my dental school like you, Stony Brook. And then I did a couple of residencies. I did a GPR at Long Island Jewish. And then I did a fellowship, what you guys now call the non-categorical year, at University of Stony Brook. That was fun because it was level 1 trauma center. And then I completed my residency at Lincoln Hospital in Bronx.
And then when you completed the residency, was that was the full 4 years, or did they get to take a year off with the non-cat year that you did at Stony Brook?
I went straight from dental school to my GPR to my non-cat to Lincoln. And Lincoln's a 4-year program.
So it was the full 4 years.
Yeah.
Right. And that's where you met Dr. Bastidas?
Yeah, he was my program director for my first 2 years at Lincoln.
Wow. That's funny how it's such a small world.
And then Filbert took over, and now I think he's down in Texas. I think he's at Parkland. Filbert was program director after Bastidas.
Lincoln. Oh, okay, gotcha. Wow. Oh, and now he's at Parkland. Interesting. And then the location, so Monte to Rochester, different, much less hustle and bustle. You didn't mention any snow. What about the snow over there in Rochester?
I brought the heat, my friend. It's been about 73 degrees.
73 degrees over there? It's warmer than
Hey,
Manhattan.
it might be warmer than Bellevue. What was it, Ariel?
Not in us.
My daughter got to go outside at school today. And Rochester.
That's great. Oh man, have you been? Like, did you know about the area at all, or are you?
No, I saw the job on LinkedIn, and I was like, I told my wife, let me apply to. They're not going to hire me. I have no experience as program director, so let me just throw my application in, set my resume up there. They brought me up for an interview. They're very nice. They're very kind. Exciting program because it's brand new. And I was like, nah, they're not going to hire me. It's, I have no experience in this realm, but they wanted to, so be it. We'll see how it works out.
Yeah, well, I think it's good. And so, was that your wife that I heard in the background over there?
My daughter is over. My wife and daughter are both here. Yeah.
And so they had to move with you, didn't they? Right? How they liking the area so far? I know it's only a month, but
it's tough. My daughter was in school in America, Westchester, so it's a big move. New friends, all that kind of stuff. So that's always stressful for her. And my wife has a practice in the Poconos. I actually practice there occasional Saturdays in her office doing oral surgery. And so she's still holding on to her practice, but she's only there just maybe 1 or 2 days a week.
Is she oral surgery as well, general dentistry? GP.
Yeah.
Oh, excellent. So you get to help her out kind of where you can.
Yeah, it's good. We get to collaborate on cases, so it's always fun to do that. Absolutely. Yeah.
She was able to keep that going while is that her office? She works in
her own office. Yeah.
Love that. I love to hear. I'm a big fan of keeping dentistry, oral surgery, mom and pop shop. I really think it's better care overall, right? When you get to know, you walk in, you know who the doctor is, then they meet your mother, your sister, your cousin, bring them in. But so how far is that? She was keeping that going while you were working at Monte for those 3 or 4 years.
Yeah, she used to commute back and forth from
all the way from. Oh, yeah. Okay. I didn't know if she was doing the.
She would leave in the morning and come back at night. Every day.
Oh my God! Well, just 2-3 days a week at that point, right?
She was in her office 4 days a week when I was at Monte.
So that's a long commute. Closer now, though, I hope, right?
What'd you say, honey?
That's a better commute than now.
It's a better commute than now, she says, because her commute now, even though it's less days, it's 3 hours 40 minutes from Rochester.
Oh,
really? But she'll go back and forth. She stays there like Monday, Tuesday.
Okay. So it's just the commute each, one way twice a week.
Yeah.
Okay. So it could be worse. But wow, when you were that's crazy. So it's further where you are now than when you were in New York. I did not expect that. That's why I asked that question.
Yeah. Huh. It's similar. I mean, her commute from Westchester to the Poconos was probably about 2 hours in the morning, maybe a little bit more at nighttime with traffic.
Got it. I mean, commuting is unfortunately, it's part of our daily life in this profession. Let's get into oral surgery a little bit. What do you say?
All right, tell me. What do you got?
What's your number one favorite procedure to do?
To say honestly, I like the variety. When I was in my private practice, I enjoyed everything from implants to wisdom teeth. Wisdom teeth, I would try to perfect it with each procedure, make it more neat, more clean. Anesthesia was a big favorite of mine. When patients wake up and they're so happy that it was completed and they're feeling good and they're comfortable. Totally elated, surprised that, why was I so nervous was a typical report to me. I did things of cosmetic nature. I did, not a lot, don't get me wrong, but I've done blephs in my office, rhinos in my office, and facelifts in my office.
In the office?
Yeah.
That's great.
So I always enjoyed the variety of things. We could be doing a simple extraction one day and doing something more extensive the next. So I think that's the wonderful thing about oral surgery. There's so much variety to it, and we should relish that. We really have a good profession where you can kind of choose whatever you want to do with this profession, and that's
right. That's right. And then because now you're working predominantly in academic setting again, hospital setting. You get to do even more variety, right?
Bigger cases, I think. I think private practice, that there's something about it where you can kind of design the procedures you want to do, the procedures you enjoy doing. In the hospital setting, it's what comes in. There's patients rolling through your doors with big cases, and you're there. It's your prerogative to treat them. So some of those cases can be scary to take. But private practice has a special place for me. And that's why I think you and I were talking not so long ago with one of your interviews where people were talking about, should you go into private practice? Should you open your own practice? Or should you go work for a DSO? And I'm still a big proponent of if you should highly consider opening your own private practice. I really truly believe that.
And now we had that background, we had the chat about it, but from your standpoint, why would you say that? You know what I mean?
I think a lot of doctors underestimate their abilities when they get out. I think if you have good customer service, which I can foresee in you, that's 90% of the battle. Obviously, you want to do right by your patients. You want to be a good surgeon. You want to be neat. You want to be clean. You want to give them a good results. But I think if you can give them a good customer service environment, that's what they'll gravitate to. Like you said, people go into these big corporate places, and I've heard this even in my own neck of the woods in Poconos, where they may go to one of those places and they come to my office and like, Dr. Helfst, I went to my dentist the other day, and it's one of those corporate places. And they said, I don't know who my dentist is. They changed last week. I have a new dentist working on me, and I'm so upset. I moved away from my dentist that I had for 20 years because of insurance or something. And I went to this place, and it's so impersonal. I see someone different every time. And they try to sell me a big treatment plan that's over $25,000, $30,000, and I'm so unhappy. So I think private practice-wise, if you can have good customer service and have good skills, I think any of the residents coming out today can be very successful in that realm. I always use it to myself. It's like a restaurant that you gravitate to. There's a reason you go back. It's neat and clean when you walk in. The people there are nice and they greet you. They know you. They know your name.
Right.
And they give you good service. You get a good product. You get good food. There's a reason you go back to those restaurants. And not to, make our profession sound small, but the same concept applies if you were running a restaurant in your office. Have great staff in the front. Have concierge that greet your patients and are nice to them and happy to see them and give them a smile. Have your office impeccably clean and neat and nice, maybe even spa-like. And you, the surgeon, has to give them that good product, that good meal, if you will. Quality surgeries, so when they go home, they're like, oh, I'm not that swollen from my wisdom teeth. Oh, it wasn't that bad. From what I heard from my friend who had their wisdom teeth out last week, and oh my God, they were telling me how horrible it was. Well, I went to this guy's office, I hardly got swollen, hardly any pain. It was great. It was a wonderful experience. That's all you need, to tell you honestly.
Absolutely. Did you start your practice just fresh out of the gates, or did you buy into something, take it over, buy it from someone potentially?
Fresh out of the gates. So I worked for this gentleman up in Scranton. Nice guy. His wife was part of the practice, the financial part of things. So that's why it didn't work out so well. And then I had a restrictive covenant of 30 miles. So I did some demographics, and I was starting to look at Stroudsburg because it's 30 miles south of Scranton in the Poconos. And the demographics, people said, well, it's not a major city, but there's a lot of influx of people who work in New Jersey, work in New York. They commute, they live in the Poconos. It's really an up and coming area. So it looks good from our standpoint. So I opened in Poconos, and I was busy within about a month and a half.
Month and a half, that's it? That's fantastic. So you said some of the residents coming out, they like to underestimate their abilities. Now, as far as opening up a practice from scratch, you said a lot of hospitality, a spa, if you will. I completely agree.
Mm-hmm.
But what about the things we even know less about, the management of a team or the business side of that practice? Where did you get these skills or understanding to be able to open that up from scratch? Because that's what I'm hearing is some of the most unexpected, where the most unexpected things come from.
That's kind of on the fly for me. I remember filling out my own claim forms back then. To tell honestly, I had one assistant. I would literally, back in those days, I would wear a pager. We didn't have our cell phones back then, but I had a pager, and I didn't want to be in the office. So I told my front desk person, who was also my assistant, I said, I'm going to go out. I'm going to go visit the dentist. I'm going to talk to them. I'm going to bring them my referral pad. If a patient calls up, if they need an emergency, page me, I'm coming back, I'll take care of them. So initially, I would see any emergencies, be available to your referring dentist. That's the key. If you can do that, they'll send you patients. Business wise, it's tough now, I think. You have to find staff who are knowledgeable with claims, calling insurances, doing your pre-Ds for you. Computerized, it's not that hard. There's so many good software programs out there now that kind of help you run your practice a little bit from a scheduling standpoint. But have a good accountant, things of that. Have a good investing person. All those things are helpful. Did I do any of that? No, I called on people knew those professions. My accountant, my lawyer, my investing person. All those people I called upon. That's
You did that yourself.
we were never taught business, definitely not in my time during dental school. So I had to kind of find people who knew that specialty and work.
They still not teach
My
me.
specialty was running a good practice. That was my specialty. I could do the customer service. I could give them a good product. I could have a friendly office staff. That I could do. The rest I could. So I called people who were, that's their specialty. Just like my specialty is oral surgery. So that's where I kind of kept that part separate, if you will. I'm not a business person by any means.
Right. I see. And you fill in the gaps where they're missing as you go. Like you said, kind of as you go, they fill in. So here's my question for you. Because you said, as you agreed, right? In dental school, they're not teaching much about business at all whatsoever. Right. And they're still not doing it today. So now you have an opportunity here. You are the program director of Rochester. And they're on the map. They're on the pass portal. People are applying. But think about this. Is there any way, even if it's just a conversation here and there, see, so this gets filed here and this is how, is there anything or any opportunity that you see to fit into just the day-to-day, maybe a sentence here and there about it, to help teach residents to do that? Because you are in support of opening up a private practice, like you said, versus just going into some other model and just being worked to death by some other organization or, for lack of a better word. Do you see any opportunity for yourself to kind of add that to the whole package of the residents of Rochester?
I like that. I haven't considered that until you brought that up. So, yeah, I think that would be a great opportunity to bring in some business people and discuss a business model for private practice. I think that's wonderful. Yeah, I haven't thought about that until you brought that up just now. But
it's just an idea.
That would be an interesting thing to include into our residency. Maybe it will be even a selling point for future residents coming to our program. Yeah, why not?
That too.
Why not?
Too. Even twice a year.
We have lectures all the time about pathology and surgery and all that kind of stuff. Why not incorporate some business into a residency? Why not? I agree.
If we're going to, instill our residents and professionals within our...
I think even if you're going to join a group practice, if you're going to join a DS or what have you, you probably should understand the business side of things. It's almost like when we're doing implants, should we understand the restorative side of things? Well, of course we should. Because when you run into your referring dentist who says, hey, I need some help in this aspect. Tell me what the next step is. You put my implant in, so I haven't done a lot of implants. Tell me the next step. It wouldn't sound good over the phone saying, well, I don't know the next step.
That's right. And it's business. It's the movement of money from one place to another in exchange for goods and services in the oral surgery. It's implants or wisdom teeth, there's some sort. But yeah, absolutely. I think a fundamental, especially if we're going to keep this part of our specialty strong. If you're going to sign a contract for 30%, you got to know what that means and how that's different from another contract that's 40, or being a private practice owner and making 50 to 55. Where's that other 20% going and why? And is it really that feasible? I just ideas. It's really good to point that out here.
I like it. Yeah.
So here's another on this kind of topic. Just a side note. What are your thoughts? I'm hearing a lot in the air, if you will. Some of these, attending some oral surgeons they're kind of thinking that over time, we don't know if it's going to be a year, 5 years, 20 years, that the anesthesia side, the dual provider surgeon, the surgeon also being the anesthesia deliverer, where do you see that going?
I think we highly need to protect it.
I agree.
It was one of my, like I discussed earlier, I think it was one of my favorite things in my office. People were so happy that we're able to give them a comfortable procedure, and they woke up and they were so elated. There's no reason why we should lose it, because if you look at our track record over time, we have a very safe profession. It's documented. There's no reason why we should lose it. It doesn't make any sense. I think what's happening is maybe some oral surgeons getting out are starting to say, hey, I got this big implant case, I don't want to deal with the anesthesia. Let me call CRNA, let them come to my office. And we're kind of doing it to ourselves. It's almost like early on, when we started to give up our implants to the periodontist because they were known to be more delicate with the soft tissue and be nicer to the soft tissues. Oh, the oral surgeons, all they know how to do is just take out teeth. They shouldn't be doing implants. So same concept. It's once you let people kind of step into that doorway and you're giving it away, then that's the problem. There's no reason why our anesthesia should be changed. Our model shouldn't be changed at all, because it's always been safe. We've always been well trained. I was so happy when I saw my residents on anesthesia rotation at Montefiore. They have such a good reputation with anesthesia. They would get the patient off to sleep, and if we had like a orthognathic trauma case, they would let my residents tape the tube, put on the gooseneck, wrap the head, And it was funny because when I had some of the new residents from anesthesia being taught by the anesthesia attending, they're so good at this. They're so good at this. And it was I was like, wow, there's something to be said about that. They loved when our residents came to anesthesia to rotate. They were like, oh, these guys were better than my residents. It's a shame. I think we're giving it away a little bit through those things where we're letting it slip out of our office. And maybe it's easier for some oral surgeons. Maybe they just don't want to do it. It can be stressful at times, but it's something we probably shouldn't give away. And I think we're doing it to ourselves. That's the issue.
I agree. I really think
if we fight for it and we show that it's safe, there's no reason why it should go. It shouldn't slip away from us. The model exactly change.
Add on and to add a few angles to that, if you look at the real literature of complications involving higher levels of anesthesia in dentistry, the literature I've read, it's not usually an oral surgeon that did that.
Correct.
Yep. And so people see dentist, but wait a minute, now we got to separate the specialties of dentistry, who's truly and adequately trained to provide anesthesia. And what level of anesthesia? Did this patient just get a certification from a weekend course?
Right.
Did they spend 6 months in an oral surgery program being a physical anesthesia resident for that entire time? I think these things need to be investigated. This is the way we gather our data and give true advocacy for, protecting that.
And at least when I was in Pennsylvania, we kind of policed ourselves, which I think is good, because I think the oral surgeons were in charge of, approving anesthesia certificates to all the specialties, pediatrics, even GPs were doing anesthesia. I was an anesthesia evaluator out in Pennsylvania, so we would go visit people's offices to make sure they had all the proper equipment and proper training or what have you.
Yes.
So I don't know if all the states are like that. I don't know if New York State is like that, but I know PA was like that. Well, you're right. We have to look at our fellow specialties in dentistry and make sure they're on the same page as we are. Because we prove we can do it.
Yes, and the last thing I would just say on that, I want to get to a few more topics, is that if you take away the anesthesia certificate or the, training or ability to do anesthesia as an oral surgeon, you take that away, what's the difference between a 4-year resident at Lincoln, at Montefiore, versus one non-CAD resident that's done 4 separate non-CAD years at different programs? What's the difference in that one?
Correct.
You could make that argument. We know the difference, right? Because the higher level you go in the training itself, you're doing more higher level surgery. Sure. But from an outsider standpoint, well, they did 1 year at Parkland, they did 1 year at Monte, they did 1 year at VCU. Right. So there's a lot of reasons we need to protect this.
And anesthesia is kind of hot for a lot of residents to do. I mean, I even had non-cats that left Monte, and they're well trained, don't get me wrong. But they were hot to get their moderate anesthesia license or ability to do anesthesia when they got out. Because some of them were like, if I don't get into a residency, at least I can join a practice and they'll let me do their oral surgery for them and they'll let me do their moderate sedation.
Right.
They were hot to do a certain number of cases for moderate sedation so they could do it on the outside.
Yes.
Whether we should allow that to happen, I'm not sure. I don't know the right answer to that. But, anesthesia is a hot topic, even for general dentists out there. They want to do their own anesthesia as well. I guess if it's safe, sure. But once again, we have the proven model as oral surgeons that way.
That's right. That's right. Excellent. What's and the CRNAs or the dental anesthesiologists that they're hiring out for, it's for the bigger cases. It's for doing zygomatic implants in the office and stuff. It's not just for taking out a tooth,
It becomes a crutch a little bit because at least in Pennsylvania, there was a lot of advertising by those guys. They even came to my wife's office, and she's a GP, and they dropped off their card. They're like, if you want to, sedate your patients, we're here for you. So they're kind of targeting all dentists across the boards, and I'm sure even oral surgeons as well. And I think, once you get into that lull where you're like, oh, well, I didn't have to do anesthesia today, I could just, do my thing. Will it snowball where those oral surgeons, I'm not saying all, but some oral surgeons will be like, oh, well, let me use them more often. Let me get away from this. And then where does the cutoff point come when, because even AAOMS and ABOMS always ask for, at the end of the year, a tally of what you did in your office sometimes.
Right.
Or they'll send me a survey. And if I had a CRNA do, 10% of my cases this year, and then 50% of my cases the next year, that's documented.
Right.
Should we continue to do anesthesia? If they look at Helfst survey and say, hey, Helfst did 10% anesthesia cases last year, and now 5 years down the line, he's doing less and less anesthesia cases. Should we still allow him to do anesthesia?
That's a good point. That's a very good point.
People get lazy. Not you, Brendan. You're very busy, apparently.
Well, I mean, there's stuff you see and there's stuff you don't see, right? But I know. So we'll wrap this up right now. And thanks for coming on again. By the way, Dr. Helfst, I really appreciate our connection now that we got this going. And now that you're not only an administrator, you're the program director at Rochester at an oral surgery program. I really want to try and push more residence information towards your way because just like you said, we're on pass in the past. And that was a challenge for accessibility to allow people to apply to your program. So this is a really big step and big news. In addition, getting someone as great, sophisticated, knowledgeable, and also you're down to earth and easy to talk to. That's something some residency programs don't have. And it's very important. It's very important. I've mentored hundreds of students over the last 3 years.
Mm-hmm.
And that's something that now Rochester has. And it might not have in the past, You know what I mean? That being said, I want to hear one last question. Let's get fun with this. There's going to be a day in the future you're going to be looking back on oral surgery and say, I did that. That's what the pinnacle of oral surgery was for me. When you think about one case, what's that case in your imagination? One or two cases where this is the dream. You know what I mean? Does that make sense?
Maybe not so much a case, but maybe my residents still keeping in touch with me when they get out. And they may have a case and they ask my opinion. And that has happened. Happily to say multiple times, that's the pinnacle. When they come back and they are happy to talk to me, excited about a case that they did in private practice, or they ask my opinion of an upcoming case, that's the pinnacle.
That's outstanding. So, and you're text me. I'm always available for help. You're a lifelong mentor. This is not just like a one-time couple during residency kind of thing.
That's what keeps it exciting. If they're excited about the profession, then I did my job.
That's the best. That's the best. I hope everyone out there in the country could say that. That's excellent.
So what's your future plans?
Future plans. Actually, I started a little bit early. I started a year. So I have this year and then another year left. That'll be my last year. I started looking about 9 months ago to see what opportunities are out there. And I'm really not so much a fan. My intuition tells me this DSO model, we need some more, and there are different DSOs coming out now. I think we need some more history under certain DSOs to say that they are better than others.
Right.
And let's see if it actually is better than private practice, right? But one thing is, though, when you get private equity involved, I think there's less protection and less respect for the surgeons. They're more so shareholder value optimizers, if you will. And I think it should always come down to patient care optimizers. I think that's the number one thing in any office of healthcare, any hospital of healthcare. So I'm looking more towards private practice than DSOs.
Nice.
It's been a very busy. We have pagers here too. I know you were saying in your office you have a pager. We got 2 pagers for the 3 hospitals we cover here. So
Nice.
those things will keep you up at night, won't they? So I am trying to move a little bit away from the hospital setting, at least for maybe the next chapter of my career. But we'll see how it all pans out. You know, you never know where the wind may take it.
So you don't think you want to take call at a hospital or be associated with a hospital when you get out? Why not?
I don't think so.
Why?
I don't think so.
Why?
I think that
It's not like you have to live in the hospital, but what's your thought about taking call for a hospital when you get out? Because when I was in private practice, I always took call for a hospital.
Yeah, if I have to, I will. But as far as the experience here with taking call and physically being in the hospital, kind of living in the hospital, it's been something else. And as far as advocacy and
it's as busy as residency by any means, but think of it like this way.
Yeah.
You know, it's great to be part of the medical community and be in touch with the people in the emergency department. You know, it's almost free marketing. Like when you go to the emergency room to, let's say, sew up a laceration when you're out of residency, you know, they'll see you, and if you do a great job and you're nice to the people, and I know you will because you have the gift of gab, you know, they'll see that. They'll be like, you know, my kid needs some wisdom teeth out next week. And Brendan did such a great job on this kid, took care of his laceration. I watched him do it. It was wonderful. I'm going to go to his office next week to get my kid's wisdom teeth out. When you're in the OR, same deal. If you have to do a fracture case, wow, he was so nice to the staff. He did a great job. His surgical skills are great. You know, let me go to his office. My kid needs some work. My family needs some work. It's the best free marketing that you could have. And you're in touch with your skills that you were trained for. Just like we talked about anesthesia, you were trained to do it. Just like you were trained to do trauma in big cases, you were trained to do it. The DSOs don't care. They want you to put in their implants. They want you to make their money. They don't care if you could do a coronal flap or fix a tough mandible fracture case. They don't care. They want you to make money for them. But little do they know, if you were there in the hospital, you would have those other cases. You would have those implant cases. Because people see you in action. And they're like, oh, let me go to him. It's more personal. They're not going to go to a clear choice. They saw Brendan work. They didn't see clear choice work in the ER or in the OR. They didn't see them. They saw you.
I like that.
So that's what I think is missing in residency now. The residents don't. That's why I think they sell themselves short. You have all these wonderful skills, and a lot of residents are about to give them away to Aspen and Clear Choice and just give them away. It's sad.
I see what you mean. That's a really good point. That's a good point. That's a side of I've had this discussion a few times. That's a side of it. I haven't considered that before. Yeah, I appreciate thinking about it that way. I really do.
Give up your skills. You train too hard.
That's right. I'm still on primary call on weekends as a third-year resident.
Don't get busy. Don't get me wrong, but it's private practice is different. You know, you're not gonna be like a resident in the hospital. The majority of the time, you're going to be your own boss in your practice, and you can kind of pick and choose what you want to do.
Right.
Believe
that's right. That's right. I appreciate that. Yeah. You know, you got to find you got to find your like home base. You know what I mean? I think that's a big part of it too. Sometimes residents just get pushed around and tossed around a bit much, and
residency stuff. Don't get me wrong. I mean, kind of hardens a little bit, but that's good. You know, it makes everything else that much easier when you move.
That's right. You're certainly right. It does. Yeah. Excellent. So that actually one last question.
I'm going to be calling out DSOs tonight. I quit. I'm not going to take your job.
It's funny. That kind of just happened 3 weeks ago. But wow. Yeah. If you were coming out of residency today,
Yeah.
And I know you said before starting your own private practice. How would you go about it? Would it be starting your own private practice from the bottom up? What would you do today's day and age if you were just coming out of residency this year?
Pick the proper location, do some investigation of what areas need an oral surgeon, where you could make some money. But I would definitely start my own private practice. You know, I know it's an expensive endeavor. It doesn't have to be. I mean, you can lease a nice spot, lease a nice location, lease a nice spot in a building, take out a loan. I think I took out a loan back in '01 for like, and it was paid off under 6 months. So,
Good.
think about it.
We might need to take out a little bit of a bigger loan.
Oh, I'm sure you did. I'm sure you did. But you know, it's if I guess my point is, if you see how much you're producing for a DSO and you didn't have to give him any of that, how long would it take you to pay off, let's say, $1 million loan? I'm sure you're easily making $1 million for them. More, I'm sure.
Yeah, I see what you mean.
A lot of my residents went into a DSO and they're doing a lot of implants, they're doing a lot of all-on-4 cases, and those are expensive cases. You know, they may be upwards of 30, 40, 50,000 bucks a case. And they may be doing a couple cases a day. So,
Oh, wow.
Do you think they can pay off $1 million loan in a year? Yeah, probably.
Probably. You have any family still on Long Island?
My sister, my brother, are still living on Long Island. Yeah.
You must come out here. You like to, you must be sitting in traffic every so often in LA, right?
Oh, of course.
You couldn't miss it. That's great. Oh, that's great. Are they going to come over to Rochester at all, or?
Yeah, they'll probably visit. Yeah, for sure.
Good, excellent. Well, Dr. Helfst, thanks so much for coming on. I really appreciate this.
Pleasure.
Really good coming on.
Pleasure.
We'll have a part 2 in the future.
I like your talks, and they're always upbeat, and I think that's important.
Yeah, absolutely. We gotta make sure we have some oral surgeons out there teaching others what it's like, right? Because if this is the best specialty, we gotta make sure people know.
I think hopefully those who are within it already have a passion for it. I've always have, and I will never lose my love for it.
Amen to that. Yeah,
but
now you're
taking the pay cut, so for sure.
But it's about the future. I side with you on that. It's always about the future. Sometimes pay cuts are required in order to lead people, the profession, the residents in the right direction.
And as long as you love what you're doing. So, sometimes pay is not the primary concern.
Right, as it shouldn't be.
But if you go to private practice, you'll make a lot of money.
Yeah. Well, we will see. If it's going to be a $1 million or $2 million loan, and it'll all work out.
What's your current chief residence plans in a couple months, because it's coming up quick? So where are they all going?
One's going to DSO North Carolina. The other one's signing with DSO in Westchester area, and the third one is.
Do you guys just take 3 residents a year?
What was that?
You just take 3 residents a year?
3 residents a year. 2 in the 6-year program, 1 in the 4. I'm the 4-year guy.
Okay, so 2 DSO people. What's the third one doing?
Yeah, the third one, he hasn't signed yet, actually. Yeah, and I've been sending him. This is insider info. I've been sending him stuff that have been coming my way. I was like, hey, look into this. This is a good spot, good opportunity. He's a little bit unorthodox. He's 46 years old.
Oh, wow.
He's got a PhD background. Excellent. Great guy, good surgeon, a friend, if you will. And I really just hope he's looking and he's going to find the right spot, because he deserves it. 46 years old, coming out of residency, he deserves something good.
Yeah, sounds good.
Yeah.
But you're right. I mean, a lot of people go to DSO. It seems to be the trend.
Yeah, I don't know. It's just, I don't know. It is worrisome, because not all DSOs are out there for the providers. And if they're not out there for the providers, how can they truly be there for the patients? And, we can throw out the excuse that, dentistry always, the trajectory always mimics medicine by about 10 to 20 years behind them. But are doctors all happy? Are they all enjoying what they do day to day? Are they all very satisfied? And I came into this, the statistics are not showing that.
Right.
The top of the charts and some of the mental health issues are in this profession. And does that have anything to do with it? I don't know. But we need to bring this profession in the right direction. And I think we should step back and reevaluate if maximizing shareholder value has anything to do with patient care. So I have my own thoughts and stuff, but I guess I really want to get into advocacy for dentistry at large. So we'll see. Maybe taking call is it. Maybe making more podcasts and going to national conventions and stuff. Who knows? Everyone's got a spot.
So what's your secret on marketing? You have a good handle on it.
Well, the secret is beta testing, if you will. In my first year of dental school, I started Students of Dentistry. It's got 100 followers now, I think. And then we made a dentist page and then a dental practice page. And I even went wineries, breweries, and cafes. Now, near the wine region, you got to check out some of those.
That's true.
But then during residency, I was like, same thing with you. It's like, I love this. This is awesome. I just want to talk about it. And turns out a lot of people want to know what oral surgery is like, what to do when your jaw is locked open and stuff. And then I actually 2 months ago, I made a startup on the side with my girlfriend and another girl in Spain, and now we are doing marketing consulting for dental practices and such. So
Nice.
it's fun,
You're the perfect private practice person.
Well, we'll see. You don't see a lot of private practice people
Because you have that gift of gab. You would do well, for sure.
I have a lot of ideas. I want to see all oral surgeons, all dentists that matter, do well.
Mm-hmm.
I want to see everyone do well. It shouldn't be a fight against insurance companies all the time, which is what it seems to be.
Yeah.
There's some good stuff in the works, I'm sure.
Sounds good.
All right, Dr. Helfst.
All right.
Go change
Pleasure,
my
Brendan.
laundry.
Keep in touch. Let me know what's going on at Bellevue. Let me know what's going on with your future. Always good to hear from residents.
Yeah, thank you. And thank you again
Keep
also.
me going.
Yeah, and congrats to you too.
Thank you.
Yeah, we'll keep in touch.
All right. Have a good evening, my friend.
All right, you too.
Take care.